Welcome back to part 5 of our Neurosurgery Coding Explainer series. Today, we're diving deep into the intricate surgical pathways to the pituitary gland. Now, if you've been following along with us, you already know that neurosurgery coding isn't just a simple game of matching a diagnosis to a number. It's actually about intimately understanding the physical, anatomical journey that the surgeon takes. So today, we're going to break down transsphenoidal approaches and finally settle the coding debate between endoscopy and microscopy. Here's our roadmap for today's explainer. We'll start with a surgical entry point, move into decoding pituitary tumor approaches, compare the torch versus mobile camera, dive into co-surgery and modifier 62, and wrap up with precision coding and documentation. Let's get right into it. Section 1, the surgical entry point. So the most fundamental challenge in all of neurosurgery is simply getting there, right? Anatomical access. How do you reach a deep-seated problem without causing catastrophic damage to the surrounding brain tissue? To reach a target like a pituitary tumor nestled at the base of the brain, a surgeon basically has to make a strategic choice between two options. They can either break the wall, which represents a traditional open craniotomy, or they can use the window, navigating naturally through the nasal cavity and the sphenoid sinus. The underlying pathology is exactly the same, but that initial entry point dictates a completely different coding pathway. Let's think about breaking the wall. This means cutting directly through the skull bone for access. Obviously, this is a major structural intervention. It requires a larger opening, significant brain retraction just to expose the lesion, and it generally results in a much longer, more intensive recovery for the patient. Because of that major cranial incision and the extensive dissection involved, this approach utilizes an entirely different foundational set of CPT codes, like 61510. Section 2. Decoding pituitary tumor approaches. Okay, so what happens when the surgeon decides to avoid this goal completely and opts to use the window instead? Navigating naturally through the nasal cavity to reach the sella turcica means we are officially out of craniotomy territory, and we immediately narrow our focus. CPT 61548 describes the traditional microscopic, transnasal, transseptal, or transsphenoidal approach for a pituitary tumor excision. The defining factor here? The surgeon navigates this passageway relying on standard instrumentation and an external microscope, completely without a camera system inserted inside the surgical corridor. On the flip side, we have CPT 62165, which represents the modern endoscopic evolution of that exact same pathway. This code is reserved specifically for the neuroendoscopic transnasal or transsphenoidal excision of pituitary tumors. So the anatomical window is identical, but the technological execution is drastically different. This approach uses a highly specialized tiny camera system inserted directly inside the nasal pathway, completely altering the surgeon's vantage point. Section 3. Torch versus mobile camera. Now here's where it gets really fascinating. Your final code selection hinges entirely on one specific clinical detail. How exactly is the surgeon visualizing the operative field? To master the difference between 61458 and 62165, I want you to think of the traditional microscope as a torch. With the microscopic approach, the microscope stays entirely outside the patient's body. The surgeon essentially aims this external torch down a narrow speculum corridor. This gives them a highly limited, rigid, and very direct line of sight. Alternatively, think of the endoscope as a mobile camera. Instead of standing outside and peering in, the surgeon takes a rigid endoscope and physically drives it directly inside the patient's nasal corridor and into the sphenoid sinus. This mobile camera provides a panoramic, high-definition, wide-angle view. The surgeon isn't restricted to looking in just a straight line anymore. They can literally look around corners and explore the recesses of the anatomy in live, real-time video. It's an incredible difference. As coders and auditors, you have to ensure that the patient's pathology and the surgeon's tool align perfectly. For these endoscopic techniques, approved clinical uses absolutely include pituitary adenomas, specific vascular malformations like angiomas, and skull-base osteomyelitis. But, and this is a massive red flag for your audits, do not report these endoscopic codes for things like acute cranial trauma, skull fractures, or intracranial aneurysms. If you are seeing those specific diagnoses tied to these codes, you need to stop and dig a lot deeper into that operative report. Section 4. Co-surgery and modifier 62. Navigating this deep, complex nasal window is rarely a solo mission for one doctor. In fact, it typically requires a highly choreographed, multidisciplinary workflow between two distinct surgical specialists operating during the exact same session. First, you usually have an ENT surgeon take the lead to perform the intricate nasal exposure and the sphenoidotomy. Then, once that pathway is perfectly prepared, the neurosurgeon steps in to handle the delicate sellar opening, dural incision, and the meticulous resection on the tumor itself. So when this collaborative, sequential handoff occurs, some very specific, hard-coding rules trigger. The rule dictates that both the ENT and the neurosurgeon will report the exact same primary CPT code. So for example, they both report 62165 if the endoscope was used. But, and this is absolutely crucial, both surgeons must append modifier 62 to that primary code. Modifier 62 indicates co-surgery, and it firmly signals to the payer that two distinct specialists were required to complete the components of this one single, incredibly complex procedure. Section 5. Precision coding in documentation. Bringing this all together requires treating the operative report kind of like a clinical GPS system. Every single word the surgeon dictates narrows down your final destination. Just like a map needs an exact street address rather than just a broad city name, you must meticulously isolate the fine details. Did they break the wall, or did they use the window? And what precise visual instrumentation was utilized to get the job done? You want to be scanning the documentation for the specific terms microscope versus endoscope. Those words act as your definitive compass. If the tool stayed outside for a limited view, you are anchored to 61548. But if the tool went inside for a live, wide-angle view, you are confidently locking in 62165. Ultimately, the surgeon's dictation tells the definitive story. It is your job as an auditor to critically read that narrative to determine the answer to one simple question. Did they hold a torch outside, or did they drive a camera inside? This single technological distinction completely dictates your final code selection and ensures accurate reimbursement as well as strict compliance. By visualizing the walls, the windows, the torches, and the mobile cameras strictly through the logic of the surgeon's narrative, you can transform a dense, overwhelming block of medical text into a perfectly clear roadmap. So the next time a complex transsphenoidal operative report lands on your desk, ask yourself, are you looking for a torch or are you looking for a camera? Your answer changes everything. Decode Healthcare with Harshal.